Hello MMA community, my name is Anushka Ranaraja and I'm DPT and a TA in the Modern Management of the Older Adult Division of the Institute of Clinical Excellence. Today we are going to talk about effectiveness of power training in older adults, but first let's talk about what's going on in the MMA community. MMA level 1 and 2 are going on right now, but the next cohort of MMA level 1 starts in March, and level 2 will be either April or May. We are popping off with live courses all across the US throughout 2024. A few that are coming up this month are Greenville, South Carolina, Clearwater, Florida, and those are January 20th. Kearney, Missouri is January 27th. If none of those work for you, hop on ptonice.com and look for a live course near you. So we're going to talk about the topic at hand now. The aging process is characterized by degeneration of various physiological systems, including the neuromuscular system, which may lead to a loss of muscle strength and muscle power. Muscle strength is the capacity to generate force over an external load. Muscle power is the capacity to generate force over external load quickly. As we age, we typically see a reduction in type 2 muscle fiber size, which can contribute to the loss of power. This decline may cause more difficulty performing daily tasks, such as getting up out of the chair, climbing the stairs, and resulting in a loss of independence for older adults, which is what we absolutely don't want. Like most of our older adult patients want to be able to live independently for as long as possible, and their children or family members or friends care about them being safe when they're doing that. So our job is to introduce power training so that we can stimulate those type 2 fibers. In the European Review of Aging and Physical Activity, there was an article published titled Effectiveness of Power Training Compared to Strength Training in Older Adults, a systematic review and meta-analysis which explored whether muscle power is a more critical determinant of physical functioning in older adults than muscle strength. The studies that they used in these were random controlled trials comparing a power training group with a strength training group, and they were included if they met the following eligibility criteria. The study population had to be consistent of older adults with the average age of greater than 65 years and recruited from a healthy population, regardless of the level of physical function. Healthy can be various things, but for them, healthy was defined according to the World Health Organization definition for health, in which individuals can be considered healthy despite the presence of chronic disease. The intervention had to be power training. The study had to include outcome measures for muscle power, activity-based tests, or a measure of physical functioning in daily life. The strength training control group was age matched and had to receive at least partially supervised strength training. They were not allowed to have anything online, or they couldn't do independent strength training instead. They assessed muscle power with chest press and leg press. They assessed movement speed with counter movement jump, chair rise measured in seconds, the SPBB or short physical performance battery, walking speed, the timed up and go, timed stair climb, and timed floor rise to stand. All really important components for our patients' daily lives, right? The tests that assessed movement speed were instructed to be performed as quickly as possible, so not typically how we are testing our patients. The conclusion of the study was that power training offers more potential for improving muscle power and performance on activity tests in older adults compared to strength training. Within the study, they note that Byrne et al. Found that muscle power was a superior predictor of functional performance compared to strength. And I'll list both articles in the comments just so you have access to them. So we know that we need to train power for functional performance, and we know that power is also an independent risk factor to strength for falls. Your call to action is to encourage or guide your patients to train power at least twice a week at 40 to 60% of their 1 rep max, which also means that you need to perform testing to assess 1 rep max, or more commonly, your estimated 1 rep max. You're going to dose 1 to 3 sets of 3 to 6 repetitions with emphasis on performing the concentric phase as fast as possible. So I have this patient who actually turned 95 today. He has to climb 6 stairs to get from his main floor to his bedroom floor because he lives on a split level home. He has access to 2 handrails. We actually started training stairs early on, but his son noted that he was just getting less stable on them. So we kind of had to figure out what was going on. He has a history of a stroke and his left side is weaker as a result. So when he climbs the stairs, his left knee kind of gives out a little bit occasionally, especially as he fatigues. So I instructed him, as we normally do, to lead with the right when he starts to fatigue and to use his handrails, but we train bilaterally. And as he fatigues within the session, I start to cue him to jump up with his left leg. So obviously I'm not having him jump off the ground, but just that word of jump and the emphasis I give, because I'm like, jump, that can actually help him stimulate to where he's moving quickly, and he's like, it's a marked difference in his ability to step up when he employs that power over just relying on strength. And if you think about it, this makes sense, right? It's much harder when you're doing an exercise with increased time under tension than if you're employing that power and just moving quickly through it. So why don't we do this with sit to stands or with stairs when our patients are really struggling? So again, power training offers more potential for improving muscle power and performance on activity tests in older adults compared to strength training, indicating that it improves functional performance, which we want for our patients. Like, most of our things are to improve function of or performance of ADLs and IADLs. So this is what we're looking for right here. Per ACSM guidelines, it is to be performed at least 2 times a week at 40 to 60% of 1 rep max or a light load. I'm probably not starting my patient off at 40 to 60% when I'm doing power exercises. Like, we are literally training body weight at this point for our stairs. We are training with a little bit of load when we're doing sit to stands. You're performing 1 to 3 sets of 3 to 6 repetitions with emphasis on quick concentric phase. If you want to learn more on how to apply this, we actually added the power component to our live course. So check out a live course near you. Again, you can look at ptonice.com for that if you want some hands-on practice. Thanks for listening, and I hope to catch you soon.